Hi, everyone. It's Terry Cook with Karen. Terry Cook with Karen. No, I'm filling in for Karen, but this is Terry Cook with Aortic Hope. And once again, we are live again tonight. As everyone knows, that it is September is Aortic Disease Awareness Month. So we're going to try and do as many lives and get people on to talk about aortic disease and all the other kinds of things. Before we do anything, I need everyone to like and subscribe to our AHTV channel so that you get notified when we have live events. Also, Facebook is another way to find our live events. So tonight we are going to talk to Ryan Rodarmer, and I am just going to let him go with it, and I'll ask questions. And please feel free to type questions in the chat, and Josh will get those to us, and we'll have Ryan answer them live. So thanks again, Ryan, for being here.
Perfect. Thank you so much, Terry. Just going to look for confirmation that you can see my slides okay?
We can.
Perfect. All right. So hello, everyone, and thank you for joining us. Today, we're going to talk about genetics, which is a topic that is incredibly important for anyone that is impacted by aortic disease. We'll start with the fundamentals, what you need to know about how these conditions or risks can be passed down through a family, what kind of questions you should be asking of your doctors, and most importantly, what you can do with that information. And this is just all to empower you on your health journey as it relates to your aortic condition. I have a little bit of a lag when I hit the next slide. There we go. So before we get started, just wanted to introduce myself. I am the Director of Genetic Education for Aortic Hope. But in addition to that, and long prior to that, I've actually spent over 20 years as a genetic counselor, entirely specializing in cardiovascular conditions during that time, and specifically what has always been near and dear to me are connective tissue disorders. And so my professional life has really been dedicated to the genetics of heart conditions. I currently work as the director of the VEDS movement, which is a division of the Marfan Foundation. And we'll talk a little bit about what VEDS is tonight as well. But I also wanted to point out that my connection to this topic is also really deeply personal. So when I was in graduate school, I was diagnosed with an aortic root aneurysm. Was monitored for quite some time, over 15 years. I survived a type A dissection in 2019. Overall, I've had 3 total heart surgeries. I had a robotic repair of my mitral valve in 2013. My graft, after my aortic dissection, my graft failed. So about a year and a half after my dissection, I had to have a third heart surgery, an open heart, to repair that graft. And then it is quite possible, it's being explored, but it is suspected that I've had 2 other arterial dissections that were not the aorta, including really recently, I've been dealing with some issues with regards to my pancreas just kind of went away. So I have to take enzyme replacement therapy now. They suspect that perhaps the reason for that is I may have had a dissection in an artery that feeds my pancreas. So it is a topic that is extremely important to me. It has shaped my entire perspective and career, drives my passion for education and advocacy. And my goal today is to really bridge that gap between the clinical world of genetics and then the real world of experience of living with aortic disease and facing those risks that might that your family may be facing.
Ryan, thanks for sharing all that, because I didn't know all that, and that's amazing. So thank you for sharing, and you are definitely a pleasure to have, and I'm so glad you're part of this organization because, as you said, it's not just your education, it's personal.
Absolutely. And Joshua has been really lobbying hard for me to do a Survivor Series story. That may be as close as Joshua gets for some time, but I do plan on continuing to do that at some point here. So here's a roadmap for our discussion. We're going to kind of start with the basics, as I had mentioned, about how genetics plays a role in aortic disease. We're going to speak very briefly about some of the known genetic syndromes that cause aortic disease, and then spend some time focusing on how those risks can be passed down through a family when they're not part of a larger syndrome. And I'll talk about what that means here in just a moment. And then some of the more practical things like genetic testing, costs, genetic counseling, what to expect. And then we'll spend some time at the end, if anyone has any questions, going ahead and answering those. I'll put a real quick disclaimer from the Marfan Foundation on the screen there, but I think the biggest point is today is educational. It's not medical advice. I'm not a medical doctor. Please always discuss your personal care choices with your own clinicians. Two big ideas, I think, to kind of set the tone. So first, If your aortic root and then your ascending aorta have problems, then oftentimes that does have a genetic basis, even if you don't have one of these larger genetic syndromes that we'll talk about tonight. And I wanted to point out, secondly, that family patterns can be really subtle. And so really the theme for today, no matter what the family history is, no matter what sorts of signs or symptoms you may have, it is important that when you think aorta, that you think family.
100%.
I'll get a thumbs up from the aortic crew with regards to the use of the tagline.
Absolutely.
So why are we talking about genetics? Because when an aortic aneurysm or dissection involves the first part of the aorta, again, the aortic root or the ascending aorta, there is a very high likelihood that there is some genetic factor involved. As I mentioned a second ago, these family patterns may not always be completely obvious. It may not be the same exact diagnosis in every person within the family. And so again, it is important that when someone has aortic disease, that it is important to think about the family. It is so vital. So if one person within the family has an aortic event, it is a red flag for the entire family to be aware of that and to be proactive about that.
And I can add I'm sorry, I can add from my own personal story is that unfortunately I didn't know. And my dad didn't even know that he had aortic dissections. So who knows if I could have been prepared, but sometimes you don't know. But now that I do know that my dad had it, I have it, my son's already been tested and everything. So it is very important whether you know or you don't know.
Absolutely. Thank you, Terry. Yeah, it is absolutely critical to at least ask those questions. Genetic risk isn't a one size fits all. We can break it down into two main types. The first is what we call single gene or hereditary risk. This is just when there is a single genetic typo in the family and one gene that is passed down from generation to generation. It is oftentimes passed down in a 50-50 type pattern. That isn't the only way things can be genetic, though. We have also what's called multifactorial or familial risk. This is when it's not as straightforward as a 50-50. It is sometimes there are some families where there may be many genes and environmental or lifestyle factors involved. And so then sometimes the patterns of inheritance aren't super clear. And so I'm getting ahead of myself a little bit, but this is why it's important to know that even if a genetic test is performed, and they don't find a single gene responsible for the aortic disease, it does not mean that there isn't a heightened risk for your close family members that may still exist. So there are two main categories here. There's single gene, and then there's multifactorial or many factors, meaning it can be many genes and lifestyle and environmental factors playing a role. The key takeaway is this: if someone has thoracic aortic dissection under age 60, especially in the root or the ascending aorta, as I'd already mentioned, and especially if that is in the absence of major risk factors, like somebody going 30 years with uncontrolled high blood pressure, if there are none of these other environmental risk factors involved, and especially if someone's under age 60, there's a high likelihood that there is a genetic component, whether we can find it or not. And our suspicion of a single gene cause then goes up pretty considerably, especially in light of a family history. So if this is something that has plagued generations, there's a high likelihood that there's a single gene involved.
With the single gene, can you explain what the 50-50 inheritance means?
Yeah, so we have two copies of essentially every gene. We have two copies, one that we've gotten from mom and one from dad.
Right.
But when this is passed down through a family, generally it's going to come from one side of the family or the other. And so generally someone who has aortic disease because of a single gene, well, they're going to have one gene that has that typo, that genetic risk in it. And then you've also got a normal working gene that you've gotten from the other parent. And so that's where this 50-50 comes in. It is strictly a flip of a coin when you have children, then whether or not they've inherited that risk factor. They either get the one that has the typo in it, or the one you've inherited from the other parent who doesn't have aortic disease. So that's where the 50-50 comes in.
Thank you.
Yeah, of course. To break things down a little bit further, and when we're talking about a single gene cause, we also have to ask the question, is it part of a larger genetic syndrome? Briefly, the example I'll use, and the one that's most commonly known as Marfan syndrome. And we'll talk about some others tonight as well. But is it part of a larger genetic syndrome, meaning other areas of the body have medical complications as well? Or is it strictly an inherited risk for aortic disease, in which case we would call it non-syndromic? And some of the other terms you may see, you can see them on the screen there, AHTAD, hereditary thoracic aortic disease, or sometimes you may see a little bit of a longer abbreviation. Oftentimes when you see 2 A's, it means hereditary thoracic aortic aneurysm and dissection. But there are some families where it is a single gene. It is still a 50-50 risk, but it's not part of a larger condition that would affect other areas of the body. This distinction is really critical because it changes everything from medical management and surveillance for the patient to how we approach screening of their at-risk family members as well. So it is really important to consider genetic testing to be evaluated for these things because, again, medical management varies pretty considerably, whether we're talking a specific syndrome or a non-syndromic thoracic aortic disease. So just to quickly check in and make sure that all the terms are clear so far. And then this is also a good moment just to kind of think about your own family. So are there any scenarios or histories that are coming to mind? If so, maybe jot down some of your questions and we'll circle back around at the end when we do our Q&A. I'm not going to spend a ton of time on each syndrome. I could dedicate an hour to each of these at least. And so this is a very broad brush that I'm painting with here. But the first major condition, and the one that most people have heard of course, is Marfan syndrome. I saw a quote the other day that really stuck with me. Well known, often assumed, frequently misunderstood. The often assumed piece I wanted to kind of key in on. How many people watching have been told that because they have thoracic aortic disease, well, then it must be Marfan syndrome. Oftentimes it's obviously not. So we'll talk in a little bit more detail about that here. But Marfan syndrome is a genetic disorder of the connective tissue. It's caused by a mutation in what's called the FBN1 or fibrillin-1 gene. We've already kind of gone over some of these terms, so we don't need to spend a lot of time, but it is passed down in a 50-50 type manner. If you think about conditions that are passed down from generation to generation, one thing you have to keep in mind, though, is they had to have started somewhere. So someone was the first one in the family to have Marfan syndrome. And in fact, about 1 out of 4 people with Marfan syndrome will be the first one in their family to have it. So 3/4 of the time it was passed down from either mom or dad. But about 1/4 of people with Marfan syndrome are the first one in their family to have that. And that's because a new genetic typo occurred at conception. Okay, so our body has little spell checkers in place where we all actually have new genetic mistakes that occur when we are conceived. Our body has a way to go in and correct those or make sure that those don't cause problems. Also, a lot of those genetic typos occur in areas that aren't really super important in our DNA. And so many of those slip through the cracks and they don't really impact our health. But if a typo happens to occur in a specific gene, like FBN1, then a child can be the first one in their family to have Marfan syndrome. And then looking forward in the future, that child's children would then have that 50-50 chance of inheriting it.
Wow.
Marfan syndrome affects about 1 out of 5,000. Oh, it is. The human body is pretty amazing. Yes. You know, and it's actually surprising. We've got billions of letters of genetic code. It's actually kind of surprising to me that there are people that walk around and are healthy because there's so many things that can go wrong, but our body has so many ways to go in and correct those and make sure that you know that we don't have those genetic risks. But you know, just if you were like if you were to handwrite a large book, like you're handwriting a copy of a large book, there's a chance that you might make a mistake, and it might be in a critical part of that novel that you're rewriting. So that's sort of the same with our genetic code.
That's a great analogy. Thank you.
Yeah, of course. When diagnosing Marfan, clinicians look for sort of a constellation of different features across different body systems. And I used the word syndrome before, and so that's what that means. In the heart, you know, usually we see enlargement of the aortic root and the ascending aorta. Folks with Marfan syndrome also regularly have what's called mitral valve prolapse, so a problem with the mitral valve within the heart. A really common feature of Marfan syndrome is extreme nearsightedness. However, more important than that is something that's called ectopia lentis, or a lens dislocation within the eye. And it is actually that combination of an enlarged aorta and a lens dislocation that really is Marfan. There's not really much else that would explain that combination of those two things. So if you have someone who has an enlarged aorta and a lens dislocation, that's essentially Marfan. Skeletal features can be being tall and slender, having a curve in the spine, or what's called scoliosis, a chest wall that caves in or sticks out, really flat feet. Interestingly, while many assume people with Marfan are hypermobile, a subtle clue can actually be that some folks with Marfan syndrome are not able to extend their elbows fully, so they actually have reduced mobility at their elbows sometimes. The diagnosis is actually based on criteria where we actually look at that combination of heart, eyes, and then there's a score that we can assign depending on how many features that we see with the person's body. There are facial characteristics, there are measurements where we measure arms and legs and do ratios and things like that. And it's kind of complicated, but oftentimes if we are considering a genetic test for Marfan syndrome, oftentimes we can have a pretty good idea of whether or not we think that person may test positive for Marfan before the test is even done, because they show, a high degree of features of it. So I've known patients who were being monitored appropriately for their aortic root and went on to have an abdominal aortic dissection. So one of the important things about Marfan syndrome is to keep in mind that the rest of the aorta may also be at risk. Historically, these folks got echocardiograms and they just kind of watched their aorta within their chest. And we're now starting to find, especially as individuals are living longer, that we should be monitoring and watching the entire aorta, not just the thoracic aorta. Care involves a multidisciplinary team, so that, again, you may see cardiology, ophthalmology, geneticist, but also orthopedic specialists, physical therapists, gastroenterologists, pain management doctors, nutritionists. I mean, with these genetic syndromes, again, they affect many different areas of the body. And as a result, you may have many different specialists that are involved in your care. This is a really important point and one that's personal to me. So after my dissection, many doctors assumed I had Marfan syndrome because I'm tall and I had just the right heart findings. So as I mentioned before, my mitral valve has been repaired. My aorta was enlarged in the exact same location as someone with Marfan syndrome would usually have an aortic aneurysm. But I didn't fit all of the rest of the criteria, and my genetic testing was completely negative. So they did not find a mistake in the fibrillin-1 gene. And to this day, I still frequently need to explain to new doctors, new specialists involved in my care, all of the reasons why I don't have Marfan syndrome. And, I'm tall and fairly thin. And so it's presumed that that's the reason, whether or not the genetic counselor with 20 years of experience says otherwise or not. Like, oftentimes that's dismissed. And in fact, it might actually be in my medical chart still to this day. I'm not entirely sure, because at a point I got tired of explaining all the reasons why I didn't have Marfan. But so I wanted to take this opportunity to make a very critical point. Misdiagnosis leads to mismanagement. And it is crucial to get the right label or the right diagnosis. However, on the flip side of that, and I've alluded to this a couple of times, we don't all have a positive genetic test. We can't always find the answer. That doesn't mean it's not genetic. And I wanted to make this point as well. Not having an answer, it may not feel this way, because having an answer is good. It makes you feel good. It makes you know that you're doing the right things. However, not having an answer is better than embracing the wrong answer. And that's something that took me a while to kind of wrap my head around as well, because I really wanted to just know. But I've undergone extensive genetic testing. They can't find the reason for why I have not only aortic disease, but it's very clearly for me part of a larger syndrome. And it would be great to have an answer, because then not only would I know that I'm doing all of the right things, but I could have a gene to test my children for to see whether or not we need to continue with their echocardiograms, because right now they're getting them every few years. They may not need to be doing that. So it would be great to have an answer, but I don't want to be mislabeled. I don't want to be managed as if I have a known
Right.
condition, because that may lead to us not making the right choices medically. So not
You
everybody
actually,
was. Go
I'm
ahead,
sorry.
Terry.
Oh, I was gonna say, you actually answered my question, because with the symptoms, obviously, just because you're tall and slender doesn't mean you have Marfan's. It almost sounds like they want just to label it and say you have Marfan's just to figure it out. Like, this is why you have
Yeah.
it, this is why you're aortic, have aortic dissection, but that's not the case. So I'm wondering that every time you have to explain, it's because they just want to label it Marfan's and then they have the answer. And that's not the answer.
And maybe in part that it's just because they don't have the knowledge that extends
Correct.
beyond Marfan.
Correct.
And doctors don't like having answers. Like, they want the answer. And so, because I am a decent fit for Marfan, I can see why they just want to say, well, this is Marfan. And so, yeah, it does present challenges. Like I said, it may be in my medical chart because I've just grown so tired of explaining all of the reasons why I don't. And, they don't have that extended knowledge base to know that sometimes we don't have answers. So, and Terry, you just made a great point. Not everyone who is tall has Marfan, and not everyone with aortic disease who has, well, excuse me, I did that wrong. Not everyone who has Marfan is tall, and not everyone with aortic disease who is tall has Marfan.
Correct.
I stumbled over that, but I think I got the point out. So again, just a quick check-in. A key point to remember, and something that I had mentioned already, is that combination of an enlarged aortic root and a lens dislocation is a game changer. That combination essentially equals Marfan. Honestly, even if the genetic test is negative, that's Marfan syndrome. There's really not another genetic explanation for that combination. And then as for imaging, again, I wanted to point out that everyone with a Marfan diagnosis needs to have surveillance of their entire aorta, not just the aorta in their chest, because as folks with Marfan are living longer, we're starting to see abdominal aortic problems as well.
Yeah, that kind of makes sense.
Another condition that is very similar to Marfan, and in fact, a lot of people that are now being diagnosed with what is called Loeys-Dietz syndrome originally carried a Marfan diagnosis for many years because it was the best fit and they couldn't find an answer. But about 20 years or so ago, we started to identify and be able to test for the genes that cause what is called Loeys-Dietz syndrome. And so, again, I'm actually kind of looking at the clock. We're going to kind of move through the syndromes a little bit faster than we had, but I think it made sense to kind of hang out on Marfan a little bit longer because it is the most common of these. So,
Absolutely.
Loeys-Dietz syndrome is, again, a relatively newer diagnosis. It was first described, like I said, about 20 years back. It is known for causing very aggressive aortic disease, so aneurysms often progress faster. And what's tricky about Loeys-Dietz syndrome is that while some people have very distinct facial and skeletal features, others can have very subtle outward characteristics or maybe no external signs at all. And I wanted to point out, I've heard many stories of doctors saying to somebody, oh, you don't need to be tested for Loeys-Dietz because it's impossible for you to have that condition because you don't have the birth defects or the physical traits that we know go along with that. Well, as we continue to add genes to that umbrella that is Loeys-Dietz syndrome, many of those genes can cause pretty aggressive aortic disease, but like I said, oftentimes subtle or no outward signs of Loeys-Dietz. So that is not true. And it is so important for aortic dissection survivors that if they're considering a genetic test, that it is a very thorough, extensive genetic test that looks at all of the genes that might explain, because again, I think the presumption was when we first started describing Loeys-Dietz, what comes to medical attention first? Well, it's those that have the most severe presentation of that. So there were children that had certain birth defects and things like that. And if you look at Loeys-Dietz in a medical textbook, you're going to have photos, images of those children that have pretty significant outward signs. And so doctors presume that that's sort of the whole story. And I know lots of adults with Loeys-Dietz syndrome that had very aggressive aortic disease. They oftentimes will dissect at a smaller size, so their aneurysms may not be as large when they dissect. And so oftentimes we'll do a preventive surgery in Loeys Dietz before we would in Marfan or in someone who doesn't have a syndrome. But, they presume that because you don't look like what's in the textbook, that's not a possibility. And again, many of the genes that have been added to the list of genes that cause Loeys Dietz syndrome oftentimes don't necessarily lead to outward signs. There's a whole group of genes, again, not going to go into a lot of detail. We don't have the time to do so, but there are a lot of genes that kind of fall under that family that causes Loeys Dietz. Just like Marfan, it's inherited in a 50-50 type pattern. And just like Marfan, about a quarter of the time, someone is the first one in their family to have it. 3/4 of the time, it was passed down from either their mom or dad.
So, I'm sorry.
Yeah,
Well, I just
go
want to
ahead.
ask a quick question.
Yeah.
So you're talking about the genetic testing and the genes, they keep finding more genes. Am I correct in saying that we should always be, or we should continue genetic testing even after we've had it once, because they're discovering more genes that could be Marfan's or could be Loeys Dietz, or more genes as to why we're dissecting?
I would encourage people to just ask that question every few years. I recently underwent genetic testing for a second time because some pretty considerable genes had been discovered in the interim. So I was last tested in 2013. And, but the problem is that if they are discovering genes and adding them to the list now, oftentimes they may only explain a very small percentage of families. And so as they add genes now, it's not necessarily making the test considerably better anymore like it did at first.
Okay.
So I do encourage people to ask that question. Since the last time I had genetic testing done, have there been any notable discoveries? Should I pursue additional genetic testing? And if they added a gene or two and the cost is low, I would say go for it, because that could explain your family. If they've added a gene or two and it increased the odds of finding something by like 0.5% and they're saying it's going to be $750, then I may not move forward with that. So yeah, so there are a lot of moving parts to that question, but minimally, I would just check in every couple of years with your doctors and someone knowledgeable to see if there's been progress and to see if it's worth consideration.
Thank you. And I probably jumped way ahead because you probably were going to talk about this later.
No, that was perfect timing.
Okay,
That's good.
Okay, so back to Loeys Dietz.
This image is a reminder to let you know that I used AI to do some of the images. And this one I left in there because it's so ridiculous and it made me laugh. So I wanted a photo of the arterial tree, so all of the arteries, and it shot this out. And I would imagine that's probably not anatomically correct, but it made me laugh so hard that it's in there. Folks with Loeys Dietz can actually have aneurysms and dissections throughout all of their arteries. It's not just focused on the aorta. And like I'd mentioned earlier, with regards to the aorta, it can tear at a smaller size. And so they will oftentimes do a preventive surgery before it reaches the size that they might wait for somebody else. And then one of the other things that goes along with Loeys Dietz is actually what's called tortuosity of the arteries, so twisting of the arteries. And just kind of like with the tall Marfan thing, not everybody who has vessels that have twisting to them has Loeys Dietz. So I just wanted to throw that caveat out there. It doesn't mean that Loeys Dietz is the answer if you've got like some twisting in arteries, especially like some of the ones in your head and neck. Like my vertebral arteries are twisted a bit. So I presumed actually when I had this last genetic test that I was going to find Loeys Dietz, and it was completely negative or uninformative, like I'd mentioned. But that is a characteristic, is twisting of the vessels. And then, like I said, sometimes there are like craniofacial features and other signs or symptoms. Some things overlap with Marfan a bit, but it is a separate entity and it's managed very differently, and that's the key. Real quick take homes with regards to Loeys Dietz. Again, first, it's always consider it as a possibility in an unexplained aortic disease, even if the person doesn't have classic features of that condition, even if someone doesn't look like the person that's in the medical textbook. Second, when pursuing genetic testing, make sure the panel includes the Loeys Dietz genes. And third, management requires ongoing imaging of all of the arteries, not just the aorta. Um, Finally, the area that's really near and dear to me, especially now, but always has been, because I worked with some families that had VEDS very early in my career. Um, and I recognized that they needed more education and awareness and support efforts than I could possibly imagine. And so, I've always loved working with families that have VEDS, and it means a lot to me. I have a picture of an umbrella because there are a lot of different types of Ehlers-Danlos syndrome. There are actually currently 13 different types.
Wow.
And they all have some things in common, but they also largely each pose their own unique risks and medical concerns. When we're talking about the risk of dissections, aorta, or other arteries, it is largely VEDS that we're focused on. So very briefly going to kind of mention some of the others here. So again, there are 13 different types. The most well-known are the classic type. These folks have very stretchy, fragile skin and abnormal scars. And then the hypermobility type is by far the most common. And oftentimes when you mention EDS to a physician that is a little bit naive to all of the rest of this stuff, oftentimes they think about hypermobility spectrum disorder or hypermobility EDS instead of things like VEDS or classic EDS. But these folks have joint laxity, joint pain, but they also have sort of a constellation of a lot of chronic health concerns, GI problems, migraines, what is called POTS, where they have issues with their body regulating their blood pressure. And so they'll get dizzy if they stand up too quick. A lot of chronic day-to-day health concerns. It is a very challenging condition to live with. It does not pose risks as it relates to arteries dissecting, though. And so that's, again, where VEDS is different. So the subtype that we really would want to focus on, like I mentioned, is VEDS. It is the most serious form because it carries the highest risk of life-threatening events. And that is not just arteries, but they can also have ruptures of hollow organs within their body as well. So sometimes there can be other subtle findings that someone might notice during the course of their life before they're diagnosed with VEDS, and that could be like easy bruising. Sometimes their skin is a little bit see-through, so you can see the veins under their skin a little bit more easily. Also, things that don't necessarily mean someone has VEDS, but unfortunately, sometimes a sudden artery dissecting or a sudden organ rupturing is tragically the very first sign that they have this condition. It is caused by mutation in a collagen gene, as are really largely all of the EDS subtypes. But for VEDS specifically, it's collagen 3A1, very important for like the structural integrity of arteries and organs. It's extremely important with regards to providing strength in those tissues. And so as a result, if someone has a mistake in that gene, then those tissues are extremely fragile. Confirming that diagnosis via genetic testing is important because it guides medical management, lifestyle decisions. So we encourage people not to do any sort of activities that might cause any sort of trauma. And it's important to understand that even with a diagnosis and proactive care, the risks really remain high. And so lifelong vigilant medical management and lifestyle modifications are important for those folks. Life expectancy is generally pretty reduced, so to compare it to Marfan, for example, Marfan syndrome, life expectancy is essentially normal now. With VEDS, we don't have medication that can lower risks because tissues are so fragile. Going in and repairing a dissection can actually oftentimes lead to the individual unfortunately not getting off the surgical table. So it is again, this is why really early in my career I recognized that this is the group that I really needed to put all of my efforts into with regards to education and awareness. We do know the outcomes are better if a surgeon knows that the person that they are operating on has VEDS because they take special precautions. Managing the condition is, like I said, pretty complex. So these folks keep a very close eye on their blood pressure and really aggressively control their blood pressure. They avoid activities where there is a risk of impact or trauma. Again, doing surgeries is extremely risky, so they generally wouldn't necessarily choose to do elective surgeries. Historically, doctors wouldn't even do like preventive surgeries because they thought the risk of surgery was too high. But we now know that it's not great to perform surgery in anyone in an emergent situation when there has already been an event, and we are starting to see that that actually outcomes with doing like a preventive aortic repair for someone with VEDS may actually, while it is a risky surgery, it may pose fewer risks than allowing that person to have a dissection at some point. So the mindset around that is changing a little bit, especially as we are training more and more surgeons to be aware of what VEDS is, and we've learned some lessons with regards to it, like within surgery, different things that the surgeon can do to take some special precautions there. There's also obviously a significant emotional toll living with this condition. Oftentimes they've lost friends and family members at young ages to VEDS as well. And so one of the things that I'm extremely focused on is mental health and self-care for this community. So again, I wanted to just pause and then we'll move on to the non-syndrome discussion, which is probably going to be most impactful for the majority of the people watching. But the main point here is to distinguish that VEDS is very different from the other more common types of Ehlers-Danlos syndrome. And all too often I've heard stories of people going into the emergency department with sudden extreme pain, which in VEDS we suspect that it is an artery dissection or an organ rupture. And doctors in the emergency department being naive to what VEDS is and saying, well, show me how hyperflexible you are. And if someone with VEDS comes into the emergency department and says, I have vascular Ehlers-Danlos syndrome, to be honest, I don't care how flexible that person's elbows are. Like, they shouldn't be evaluated for hypermobility. They need to get their imaging as soon as possible so that we can make life-saving choices for them in the emergency department. And so it is critical to recognize that VEDS is not similar to the other types of EDS in that regard. It is a very different condition that needs to be managed very differently. Okay. Those are the main genetic syndromes that we know can cause thoracic aortic disease. So now we'll move on to the sort of the non-syndromic side, and this is where the majority of people will fall. Non-syndromic HTAD, or hereditary thoracic aortic disease, is exactly what it sounds like. It's an inherited tendency to develop aneurysms or dissections of thoracic aorta without other features of a larger syndrome like Marfan. Oftentimes, this is only discovered after someone in the family has an aortic event, because you don't have any clues on the outside, because you may not have any related symptoms or health concerns. And so that's why it is extremely important, and it's such a powerful tool to take a good family history. We may not always be talking about a parent or a sibling. It could be a first cousin who had a dissection at 32 that really gets the family thinking. And so a really good detailed family history is extremely important when it comes to non-syndromic HTAD, because again, we don't have other clues. That's all we've got to work with.
So you brought up a point you just said about cousin, a cousin may have had. How far out in the line or the family tree would you go for that, for your family history, or how far out should you go?
Yeah, it's tough too, because the further back you go, you may get incomplete stories, or something may have happened so long ago that an autopsy wasn't done, or they may have used the wrong medical terms to relay that story down through the family. So you got to be a little careful if you go too far. Okay. But one of the things that goes along with this 50-50, what's called dominant inheritance, one of the things that we can see is what's called reduced penetrance, meaning you can carry that genetic risk and never develop the medical problem associated with it. And so you might have a grandchild who has a dissection at 32 and a grandparent that had a dissection at 45, and then the parent in between is now living into their early 60s or late 60s, no aneurysm at all. I would presume that parent carries the gene, carries that genetic risk, but for whatever reason, whether it's making all of the right choices with regards to diet and lifestyle, or maybe some protective genes that they may have in place for whatever reason. That parent never developed an aneurysm yet, and maybe they won't ever, but it looks like it skipped a generation. Well, we know that a gene typo can't skip a generation, but we know that sometimes people can carry that genetic typo and not manifest whatever medical concerns might go. So to your question, it does get challenging when we go too far out. And if it is a 50-50 chance, generally we would see more people in the family with aortic aneurysm or dissection than not. So if your immediate family, if there's none of that, then I'd be hesitant to go really far back, because you're going to find someone with heart issues that died at a young age. Like anybody's family, if we go back far enough, we'll find that answer, but it's not really an answer, right? It's like it's a suggestion or a hint that maybe we need to take with a grain of salt. So yeah, it kind of varies. That's a tough one to answer.
You did,
but go ahead.
No, I said you did.
Okay, very good.
Thank you.
Yeah, of course. These genes also that we know that cause non-syndromic HTAD, also 50-50 chance. If someone has tons of features of Marfan, for example, when we go into that genetic test, we have a very high likelihood of finding something. But if we're talking someone whose history doesn't scream Marfan or Loeys-Dietz, even if there's a strong family history, like even if there are aneurysms multiple generations in a row. So as an example, my dad and his two sisters all have aortic root dilatation, same spot as mine. And my genetics was completely negative, and I did what's called an exome test. We looked at all of the genes, and there are. I just have to say there are genes we haven't discovered yet. There are genetic mechanisms we don't understand and can't test for. Maybe we're looking in the right place, but not looking in the right way. There are all sorts of reasons why we might not always be able to find the answer, even in a family where it's clearly being inherited. And right now the yield is like 20% or so for families like mine. And so, I would say if someone's having a genetic test, we can be hopeful that an answer is found, but I wouldn't go in with too high. You need to mentally prepare for the chance that that's not going to come back with an answer. And unfortunately, that happens more times than not. Still, we've got a lot to learn. So how do we act on this information? So if you have a family with thoracic aortic disease, especially at young ages, especially if we take out major environmental, lifestyle risk factors, etc., no signs of a syndrome. If we don't find the gene, we still need to think about approaching it as if it is hereditary, meaning if the genetic test is negative, we should still consider getting echocardiograms on first-degree relatives, and that would be parents, siblings, children, because of what I just showed you, that 20% pickup rate with these genetic tests. And, so using, again, my family as an example, with my history, the fact that dad and both of his sisters have enlarged aorta in the same spot as mine was, there's no doubt in my mind that I will continue to pursue echocardiograms for both of my kids. That's what I have to do at this point to keep an eye out on them. I can't do a genetic test to see if they've inherited the gene from me because my genetics was negative. So we have to get an echo on them. Diagnosis and management rely on a combination of many tools. So it's the imaging, it's the thorough family history, and it's the genetic testing. And all of those things may not lead to an answer. And so that's when we just need to sort of make an educated decision that and recognizing that we don't know everything, and just doing the right thing and watching those family members who are still theoretically at risk, watching them for aortic aneurysm. So to move on to the topic of genetic testing, looking at the clock, I think we're doing pretty well. So we're going to have probably 10 minutes for Q&A, not 15. Genetic testing offers huge benefits. So again, first, it can clarify the diagnosis. It can influence the timing of imaging and surveillance, but also the timing of preventive surgery. And again, that's the key, is if we can identify an aneurysm early, we can do a preventive surgery to avoid that catastrophic risk that can go along with dissection. We're fortunate to be sitting here telling our stories and educating, but many people don't make it to the hospital, or they make it to the hospital and they're turned away and they go home and they're not able to then go back to the hospital. So
Yes.
timing of preventive surgery is extremely important, and it is much lower risk than waiting until an emergent situation, for sure. If a syndromic cause is found, like Marfan, Loeys-Dietz beds, etc., it triggers the need for surveillance of other areas of the body, other types of management decisions that need to be made. And third, and perhaps most importantly, finding that specific genetic cause in a family allows us to do then targeted genetic testing for those family members who might be at risk, because we can determine who needs to be watched by cardiology, and despite a strong family history, who has not inherited that risk and who doesn't need to worry about that at all. And as I'd mentioned earlier, genes don't skip generations. So for example, if we were to find the gene in me and my son were to test negative for that, his future children wouldn't be at risk either, because if he doesn't have that genetic typo, he cannot pass it on. So lots of reasons why genetic testing can be extremely helpful. And then also, if genetic testing is negative, I would still argue that that was helpful information because you've ruled out a lot of things. But again, I would want physicians to not necessarily take that genetic test result and have that translate to, oh, then there's no genetic risk within the family, because that may not be true. The strategy for genetic testing is we always want to start with someone who's most likely to carry that genetic typo first. So someone in the family who has had a dissection, someone in the family who has an aneurysm, because if we test someone who's asymptomatic, why were they asymptomatic? Were they asymptomatic because they haven't inherited that gene that's in the family? Was their genetic test negative because perhaps this is a family where even if we had tested the person with the aneurysm, we weren't going to find anything because it's one of these genes we haven't discovered. So it is critical to start with someone who is the most likely to have genetic aortic disease first, and then go from there. If we find something, then we can test others. If we don't find anything, and we know there's no benefit of testing other family members, because if we don't find it in that person, we're not going to find it in anyone. Let's see here. I did also want to point out that talking with a genetic counselor doesn't obligate you to have a genetic test. It is their job to make sure that you are making an informed decision. So they'll talk about all of the things that one would want to know: cost, insurance coverage, discrimination concerns, all of that. Going to see a genetic counselor doesn't obligate someone to have a genetic test. And so I always encourage people at least just have that discussion, so that even if you decide against genetic testing, at least you are doing so with all of that knowledge in your pocket. Again, it's important to have very realistic expectations. So the number of genes on a testing panel can vary from lab to lab. Chance of finding an answer depends on that person's specific features, how strong their family history is, etc. But I would encourage people to mentally prepare for that genetic test to not find an answer, because that does happen quite often. But also be prepared to advocate for your family in terms of making sure that they continue to get that imaging that they need. As it relates to cost and insurance policies and all of this, so many plans do cover genetic testing. High deductible plans are a problem no matter what type of medical interventions or treatments or things that we're talking about. So high deductible plans are a problem, but many labs have what's called a self-pay discounted rate. So if you choose to just not bill insurance in that scenario, they might cap the cost of the genetic test at $250 or something like that. And historically, and still to this day, actually, doctors think like, oh, we're talking thousands of dollars. Not always the truth. And if a gene is found, oftentimes many of these labs will actually perform free genetic testing in family members within like 90 days. And then even if you're beyond that point, testing for a single genetic typo is way cheaper than doing one of the larger panels when you're still trying to find answers. And so oftentimes it can be pretty affordable. It's the genetic counselor and their department's job to actually figure that all out. If a prior authorization needs to be submitted, they'll write a strong letter advocating for you to get coverage, and they can determine costs and figure out what it will look like before you actually go through with a genetic test. And I would encourage people always to make sure that you do have those answers before you have a genetic test done, because especially for people with high deductible plans. I mean, it can be thousands, but it doesn't have to be. And so let the genetic counselor do their work and figure out what that cost will be for you beforehand. I'd already mentioned this here, but again, there are self-pay options and many labs have those in place. So you know going in that it's capped at a certain cost. And but you do need to elect to take that route before a claim is submitted to your insurance. So that's why you're proactive and you let the genetic counselor talk about your options with you beforehand. For those with Medicare and Medicaid, it can be challenging. I would again encourage you to talk with a genetic counselor because they are aware of which labs do things like cap the cost, or if someone has Medicaid or Medicare, depending on which state you are, and things as well. But some of these labs will have a policy in place to say, Medicare doesn't cover the genetic test, but we're not going to balance bill the patient who has Medicare. And so again, it goes back to the importance of involving a genetic counselor. If there's not a genetics department in your area, there's also telemedicine choices. So there are a lot of genetic counselors that are licensed in many states, and they actually have telegenetics services where you can actually just kind of do a video chat. And I'm being mindful of the time, and we don't necessarily need to spend a lot of time here, but I did want to point out preparation for your genetic counseling visit is key. Gather as much of your family history as you can. If there's a family member that was suspected of having Marfan syndrome, for example, bring some photos of them, because it is helpful for the genetic counselor and geneticist to look at photos of that family member where they can kind of see what that person's like body style or body type was, or if they had any facial characteristics, etc. So do gather as much information as you can beforehand to maximize that visit. And then what that looks like is you typically meet with a genetic counselor first. They would talk about, like I said, insurance discrimination, and they would educate you about inheritance patterns and the odds that they think that a gene might be found and all of these things. And then if a genetic syndrome is suspected, then oftentimes a geneticist or genetics doctor would come in and do a detailed physical examination to look for those clues, because that might be a super important part of the prior authorization letter or things that they're trying to submit to the insurance company to get it covered. And even if a syndrome is not suspected, they may actually do a brief physical exam just to be able to, in your note, say the things that they're not seeing, right? So, they might do some measurements to say this person doesn't have a Marfan body type, for example. So there can be a physical exam piece. Obviously, they can't do that with telemedicine. So over the phone, the doctor might just use video to take a look at you really quickly. But in person, sometimes they'll do some measurements, measure how long your arms and legs are, again, either to rule in or rule out signs of things like Marfan syndrome. Genetic testing takes usually about 2 or 3 weeks to come back. My most recent one, that exome test, like I said, is a lot larger. That one still only took like 4.5 or 5. So turnaround time is actually not too bad. And then based on those results, they'll make referrals. They'll suggest potentially more genetic tests. If something is found, they'll come up with a plan with regards to what's called family cascade testing, meaning testing those at-risk family members for the gene that was identified. If nothing was found, they may actually relay back to the cardiologist the surveillance recommendations for your children or for your siblings or parents. So, they take that information and they come up with a plan with regards to how to move forward, depending on what they find or what they don't find. Big picture recap. So, ascending aortic root, we assume genetics until proven otherwise. We match a condition to a care plan, so that's why diagnosis is extremely important, because it impacts management. Testing clarifies management and protects family members as well, and costs are potentially not that bad, and we employ genetic counselors to kind of do all of that legwork for us. I threw this slide at the very last minute in, but I just did want to point out that for those families where we don't find a gene, there are still recurrence risks. And again, it's because we know that there are other genes and shared environmental factors within a family. And so there are risks to family members, even if we can't find a gene. And so we do know that some of that data. So the first degree relatives of someone who has thoracic aortic disease, about 10 to 20% of first-degree relatives are affected as well and should minimally have an echocardiogram periodically. Depending on the family history or what they find, they may need CT scans or MRIs as well. Abdominal aortic aneurysms are a lot less likely to be a single gene involved, but we do see recurrence risks in family members. So first-degree family members of those with abdominal aortic aneurysm, again, provided we're taking out things like, like smoking, cholesterol issues, all of these things that can cause aneurysms to develop. But about 15 to 25% of first-degree relatives of those with abdominal aortic aneurysm, especially males. Males are a higher risk genetically than females in that situation. And then something else that I didn't mention is bicuspid aortic valve. We don't really know genes that cause bicuspid aortic valve, but we do know that there's an associated risk with developing aortic aneurysm with that. About 10% of first-degree relatives will also have a bicuspid aortic valve, but if that is ruled out, if they have a normal aortic valve, there is still theoretically a risk to develop an aortic aneurysm. And so none of the guidelines really state this yet, but if it were me, if I had a bicuspid aortic valve and my children did not, I would still lobby for them to get echocardiograms periodically when they reach adulthood, because there is still a theoretical risk that they could develop an aneurysm. All right, so another AI image. I thought it would be really cool to make a question mark in the shape of an aorta, but now that I look at it, it's kind of creepy. As a reminder, not a doctor or medical professional. Well, I am a medical professional. I'm not a physician. So we'll cautiously take questions, and I may actually ask some of you, depending on the question, I may actually ask you to reach out to me directly, and we can get some physicians involved. I work with a lot of specialists at the Marfan Foundation that are willing to answer questions as well. We've got various resources there. Mostly I wanted to point out Aortic Hope has an 8-part blog series that I did. And so you can reference that. And I'm going to throw my email up there while we see if there are any questions. The joke at the foundation is I'm long-winded, and I proved it. I'm going to hop off. I'm waiting for Joshua to say, Ryan, stop sharing your screen.
Whenever you're ready, Ryan.
As soon as I find my mouse, I can't find it. There it is. Boy, I wish I had a touch screen right now. I can't find my cursor. It's showing up periodically.
As I say, I can see it every once in a while.
There's my cursor. I got it.
Awesome.
All right. Let's start off with saying hi to people in chat. We've got Molly, Velda, Rob. That's Chef Rob, of course. Tom and Christina. When we were into Think Aorta, Think Family, Tom shared with us his son, 54 years old, was just diagnosed with a 4.4. He's in watch and wait. He's a 12-year survivor. His father and brother died from aortic disease.
Wow.
We have a question in the chat. Would a father with an abdominal aneurysm and a daughter with aortic aneurysm and dissection be considered genetic?
Yes, and so in theory, those things may very well be related. Depending on the age of the father's abdominal aortic aneurysm, that is also potentially coincidental. But, and unless there are signs or symptoms of a known syndrome there, it's one of those families where I would suspect that the odds of finding a gene would be on the lower end, but you've got 2 first-degree relatives with aortic disease and daughter potentially, I'm presuming young. I'm not sure if I caught the age, but I would say that that's definitely a family where at least having that discussion with a genetic counselor, with a geneticist, to entertain the idea of seeing if we can't find an answer. And then coming up with a plan for at-risk family members, depending upon what the results are. I would say that that's definitely a family that where it would warrant at least having further conversation about it.
Excellent answer, sir.
Thank you.
We've got an anonymous statement in here. Good evening, and thanks for this important segment. I had an aortic dissection in September of 2017. Aortic arch to iliac crest, all 3 layers. Now my children who are in their 30s are experiencing some medical issues relating to cardiac. One of their doctors suggested that I go get genetic testing. I go this Friday for my first visit. I'm hoping to find some answers that I hope will benefit my family.
Very good. Yeah, I hope for answers too. And again, I want to remind you that answers can look differently from one family to the next, and be careful about having expectations about what those answers would look like, because again, even if you pursue genetic testing, if it is negative, or I would rather call it uninformative genetic testing, it has still ruled some things out. And again, knowledgeable providers will take that information, take what they know about your personal history, and I would hope put that all together and come up with a responsible and informed plan about how to manage things with regards to the kids. You know, I don't know the details of the heart issues for the children. It could be unrelated things as well. Unfortunately, heart disease and heart-related complications are so very common in our population. I think a lot of that is like, diet and activity related, and there are other things that can be genetic too. So if we take the aortic history out of there, there could be some other potentially genetic risk underlying, some of the heart symptoms that the kids are having. So also I wouldn't leave it at that. If you come out of all of this and don't have answers, I would encourage their cardiologists or the geneticists to kind of look at the details of what's going on with the kids' hearts, and just make sure that we're not missing something, or just presuming that all we need to rule out is aortic disease. If they're having heart-related symptoms, it could be something else that they might want to explore. There are genetic causes for heart muscle disease. There are genetic causes for heart rhythm problems. And so, I think a good informed genetic counselor or geneticist will want to see the big picture and just make sure they're not missing something as well.
Well, it's funny, along with that whole thing that they're going to Friday for genetic testing and stuff, you talked about a while back in your slides, talked about the mental preparation. And that is a key thing that I know personally, I wish I would have known about. That, you have to be prepared mentally that there may not be an answer. And that, like you said, you're still going to rule stuff out. So that mental preparation is really important. And like I said, I wish I would have known. There's a lot of things I wish I would have known before all this happened. But that's something that people need to definitely think about before they go for genetic testing.
Sure. And one of the natural emotions, if you don't find an answer, is disappointment. And that's okay. And I'm not
Absolutely.
saying don't be disappointed that that's the answer. I mean, I went in obviously extremely informed with my most recent genetic test, and also was like going after pretty much the largest genetic test that it was available outside of one that I couldn't afford. But I mean, we cast the net really wide, and given my family history and the fact that a couple of genes had been discovered, one of which I was very suspicious of, I'm disappointed, right? I mean, it would have been great to find the gene so that I could test my children and know that they don't need to potentially have echoes for the rest of their lives. And it's just not the way it worked out. But I'm also in the same place I've been for now 20 years, right? It didn't change much. Like it was an opportunity to find an answer. We didn't. So now I'm in the same place I've been, and I had come to grips, or had come to a point where I was okay with that. So I just needed to remind myself, okay, well, I'm just in the same place I've been all along.
Right, right. Any other questions?
So the daughter's age was listed at 56 and the father is in their 70s.
Okay. Yeah. So, so under age 60, unless she had significant other like environmental lifestyle risk factors there, yeah, I'd argue it's worth pursuing. Again, I wouldn't go into it necessarily getting my hopes too high that an answer is going to be found. But, part of that again is ruling some things out that honestly, like some of those genetic syndromes, it's better to have aortic disease not as a part of a larger genetic syndrome. So having those tests come back negative can provide some peace of mind that it's not something bigger. And, with regards to the family, we can just kind of focus on the aorta. So yeah, given the family history, I think it's definitely worth asking that question, looking into the costs and things like that. But that's another spot where you bring in sort of that cost benefit ratio, and that, if you're on sort of the lower end of the spectrum with regards to odds of finding an answer, and they come back and say it's going to be a $1,500 genetic test, versus coming back and saying there's like a $50 copay, I might make a very different decision about whether or not to pursue it. But I would lose sleep at night if I wasn't asking that question and looking further into it.
Correct. Makes sense.
I like that. That catches us up with chat, and I don't see any more anonymous questions.
Great. Well, I just want to thank you again, Ryan, for all your informative information. Thank you also. I don't think I've ever thanked you for writing the blogs that we have out on Aortic Hope. Definitely take a look at those, read those, and reach out to Ryan if you have questions. You can reach out to us, and then we can also contact Ryan as well. So I just want to remind everybody to like, subscribe, and I think I forgot to say share. Like, subscribe, and share our videos on the YouTube channel. And if you have any questions, reach out to us. And we are looking forward to, I think we have another live event on Thursday. You may see me again. You might see Karen. I don't know. But again, thank you again, Ryan. Thank you, Josh, as always. And we hope to see everyone soon. And stay healthy.
Thanks, everyone.
Bye.